So in this segment of our lecture for the module on causality and observation versus experiment, we're going to talk about one of the early case control studies published in 1950 about smoking and lung cancer. So this is how the actual journal article looked, British Medical Journal from 1950, and Dahl, who was an MD, and Hill, who was a PhD and a mathematician, teamed up and did this study and published it. So the article itself is, to our current way of thinking, we would say this is a very wordy and overly long publication in a medical journal. But if you actually sit down and read it, it's actually quite delightful, and to me, they explain things in a really nice way. So first of all, in their introduction, they say that the rise of lung cancer in England and Wales seems to have been particularly rapid since the end of the First World War. The death rate of men ages 45 and over increased six-fold, and women of the same ages approximately threefold. This increase is still continuing. It has occurred too in Switzerland, Denmark, the USA, Canada, and Australia, and has been reported in Turkey and Japan. So a rise of lung cancer deaths. So something that we should stop and ask ourselves at this point is, in 1950, how do they know that death rates for lung cancer in all of these countries changed in the years between the First and Second World Wars? Did they Google it? Did they look on Wikipedia? No. So where is that data? So as epidemiologists or budding epidemiologists, we're always going to ask ourselves when we hear these statements about, oh, such and such disease is increasing, this is changing, whatever. We're going to ask ourselves, first of all, what are the data? What data support that, and how do they know? So the answer in this case is that death certificates and birth certificates are the two public health records that have been constants for more than a century in the Western world and are considered to be very complete. If you were born or if you died, there is a certificate keeping track of that. And so what people had to actually do then, though, to accumulate statistics is to go through the paper death certificates and start writing down tallies. Oops, here's another lung cancer. Oh, here's a heart attack. Oh, here's a pneumonia. So someone literally annually is as those death certificates are being created and coming in to public health agencies or vital statistics agencies, they are tracking all this information. So all the way since the First World War and the Second World War is the data that they looked at to make the statement about the rise in lung cancer. Okay, so back to this study about the reasons for the rise in lung cancer, the possible causes of this epidemic. Many writers have studied these changes, considering whether they denote a real increase in the incidence in the disease or are due merely to improved standards of diagnosis. And I think you can probably think of analogies in your clinical area today where you're using a different diagnostic standard or a different diagnostic definition, and that might create a different apparent rate of disease or amount of disease. So that was a possibility. But Dahl and Hill go on to say that two main causes have been from time to time been put forward: a general atmospheric from the exhaust fumes of cars, the surface dust of tarred roads, gasworks, and so on, and two, the smoking of tobacco. And so it was well known to them that pre-rolled cigarettes were pretty much not available before the First World War, and smoking and manufactured cigarettes became very much available between the First and Second World Wars. So that's all from the introduction. So now Dahl and Hill are proceeding to conduct a case control study. And so they explain in great detail their methods because they're not assuming that a case control study was a common thing that people had done before or had read about before. And so they're explaining in great detail, but doing a really good job of documenting their study. So they say the investigation was planned to determine whether patients with carcinoma of the lung differed materially from other persons in respect of their smoking habits. 20 London hospitals were asked to cooperate by notifying all patients admitted to them with carcinoma of the lung. An almoner, who was kind of a social worker but who was trained for the research, visited the hospital to interview the patient using a set questionnaire. As well, the almoners were required to make similar inquiries of a group of non-cancer control patients. So hence the phrase case control study. The lung cancer are the cases and non-cancer controls. So who should those controls be? Who would you want to compare the smoking habits to your lung cancer patients? Well, they wanted the control patient to be of the same sex, within the same 5-year age group, and be in the same hospital at the same time. So this last one, the first two are for scientific reasons. If the person is developing a new case of lung cancer, the comparison for that person is probably someone of the same sex who has lived approximately the same number of years and has not developed lung cancer. But the issue of being in the same hospital is really more for the research convenience. And in fact, the true comparison group, we in epidemiology today would say the best comparison group would be people who are out in the community and don't have lung cancer and aren't even in the hospital. But in those days, this was, and in many situations, this is a feasible way to do a study, is to use control patients from the hospital. So from these cases and controls, they wanted to know the smoking history. So they say that the assessment of the relation between tobacco smoking and disease is complicated by the fact that smoking habits change. The difficulties can be largely overcome if a more detailed smoking history is taken. For example, one man who was described in the hospital notes as being a non-smoker admitted to the almoner that he had been a very heavy smoker until a few years previously. And I'll just comment that this is exactly the same scenario today. There are many, many people who, your medical records will say that they are a non-smoker, but they actually are a former smoker, which is a different thing in terms of their health risk. So Dahl and Hill are recognizing this issue. So it was necessary to define what was meant by a smoker. Did the term include a man of 50 who as a youth smoked a couple cigarettes? A smoker was therefore defined in this inquiry as a person who had smoked as much as 1 cigarette a day for as long as 1 year. To assess their reliability, 50 unselected control patients were interviewed a second time 6 months or more after their initial interview. So, and this is also a method that is very much used today. So many things in this article are sort of principles of conducting a good study that carry through right to today. So if you're interviewing people, how good are their memories? How well do they understand your question? How completely do they respond to your question? One way of assessing that is reliability and asking the same person the same set of questions on 2 different occasions. So the results of their study, they first of all describe, of course, the patient population that they actually studied. So they said that in these 20 London hospitals, 2,370 cases were identified. A few were excluded from the study because they were more than 74 years old, which is 150, because the diagnosis initially reported as making them eligible for the study turned out to be incorrect. They did not have lung cancer because they could not be interviewed, which again, these are the same issues, right, that you'll see in this day and age when you're conducting a study. If someone is so ill that they can't be interviewed, or if they do not speak the language of the interviewer, or they have hearing problems or communication problems. So 408 could not be interviewed. 11 had replies judged unreliable, and none were reported to have refused the interview. So out of 2,370 cases identified, 1,732 were interviewed. So if you were conducting this study today, you would be congratulating yourself like crazy for this really excellent completeness of your responses to the study. Dahl and Hill apologized for that. They said, oh, the proportion not seen is high, but there's no apparent reason why it should bias the results. It was in the main due to the time that inevitably elapsed between the date of the notification and the date of the almoner's visit. So in other words, with lung cancer, the researchers would be notified about someone having a diagnosis of lung cancer, but maybe by the time someone actually got there to recruit them for the study, that person may have died or for some other reason was no longer able to be interviewed. And so, but the key issue here is, should this bias the results? Does non-participation in a study or does loss of a study participant from a study, how might that bias the result? This is another issue that this is an issue that we are going to talk about a lot during the semester. And it's a really key one in terms of observational studies. All right, so here are Dahl and Hill's results in terms of the smoking and lung cancer association. And this is a little bit blurry, but it is a reproduction of the actual table and the way that they presented it. So they title it The Proportion of Smokers and Non-Smokers in Lung Carcinoma Patients and Control Patients. So So here's your lung cancer patient. Your lung cancer patients are on the first row here. So the number of smokers in the lung cancer patients is 647 out of 649. And the number of non-smokers is 2. Okay, but now we look at our control patients in the hospital with diseases other than cancer. The number of out of 649 total, 622 were smokers and 27 were non-smokers. This is among the males. So first, when you see that 647 out of 649 were smokers, you're like, well, there we go, really strong association. But that's why we have control groups. Apparently, in the years that this study was being conducted in the late 40s, most adult males in London were smokers. And so among even the patients in the control group, they only found 27 non-smokers. Turns out that the difference between 2 non-smokers and 27 non-smokers is highly statistically significant, but it's you can ask yourself, how convinced are you? So if you were a doctor in 1950 and you read this paper and saw 2 out of 649 non-smokers compared to 27 out of 649, would this be enough evidence for you to say, oh, I'm going to change my thinking. Whatever they taught me in medical school, I now have changed my mind. I think smoking is a cause of lung cancer. I think I should be advising my patients not to smoke. Is this enough evidence for you? There's more evidence coming up if it's not. Okay. Among the females, there were only 60 female lung cancer patients. Out of those, 41 were smokers and 19 were not. The 60 non-lung cancer controls among women, there were 28 smokers and 32 non-smokers. So again, in every group, cases and controls, we have some smokers, we have some non-smokers, but the proportions are somewhat different. And so for the females, just because the size of the study population is smaller, statistical significance is not as strong. But again, that's the evidence, and this is one of the very first studies rigorously conducted making this comparison. So the message, to get you motivated for this course, ask yourself, how convinced would I be by these data? What would it take? What would I need to know to change my thinking about cigarette smoking and lung cancer? So another aspect of the same case control study was looking at the number of cigarettes per day that each individual reported that they smoke. And so with the cases being in orange and the controls in that sort of aqua color, we do see that especially people who were very heavy smokers, 50 or more cigarettes per day or 25 to 49 cigarettes per day, cases, the orange, really do predominate. Whereas people who reported that they smoked but smoked only, say, 5 to 14 cigarettes a day, controls somewhat predominate. So again, you're reading this article, you're a doctor in 1950. Is this enough evidence to persuade you or to recommend to your patients that they cut down on smoking? And among the women, we see the same thing. There aren't the 50 and over cigarettes per day, but among the heavier smokers, we are seeing more orange, more cases in the more cigarettes per day groups. So this case control paper by Dahl and Hill, they addressed a lot of methodological issues, which are really the same issues that we think about today when we read an observational study and we ask ourselves how convincing this evidence is. So they talked about measurement error, the exposure, which was smoking, how reliable, how complete were the information about people's smoking history, was the disease diagnosis correct, was there bias, was there selection bias in terms of who participated in the study, was there information bias or confounding, and what was the role of chance in terms of, and they addressed this by reporting the p-values. So their conclusions were that, to summarize, it is not reasonable, in our view, to attribute the results to any special selection of cases or to bias in recording. In other words, it must be concluded that there is a real association between carcinoma of the lung and smoking. As to the nature of the carcinogen, we have no evidence. So pretty strong conclusion after a lot of very carefully worded discussion of all of these potential biases and confounding. This is their conclusion. So Other people looking at their data did not reach the same conclusion. So notably, the statistician R.A. Fisher, who was another British mathematician and statistician, and he's quite famous if you ever use something called the Fisher's exact test. This is Dr. Fisher. So he expressed skeptical views of the causality of the tobacco and cancer link. One issue that he brought up is what he called the constitutional hypothesis, that both characteristics, that is, smoking and lung cancer, might be largely influenced by a common cause, in this case, individual genotype. And so he actually had some data about twins and smoking habits in twin pairs. And what he found was that monozygotic twins very often had alike smoking habits, whereas dizygotic twins were equally likely to be alike or unlike the other twin in their smoking habits. And in fact, a lot more research and a lot more information about genetics and DNA today does show that there is a genetic component to addiction and to things like smoking habits. So Fisher is not wrong that smoking and becoming addicted to substances like this might have some kind of genetic component to them. But does that invalidate Dahl and Hill's finding? Only if the same genetic aspect that makes you a smoker is also making you susceptible to lung cancer. A different point raised by Fisher was that the direction of causation may be reversed. Is it possible then that lung cancer, that is to say the precancerous condition which must exist and is known to exist for years, is one of the causes of smoking cigarettes? The precancerous condition is one involving a certain amount of slight chronic inflammation. It is not likely to be associated with smoking it's not unlikely to be associated with smoking more frequently or smoking rather than not smoking. These are some really interesting questions that Fisher is raising. And, he was not alone, but he certainly was very prominent as a very important statistician in raising these questions. And he certainly, they say that Fisher went to his grave a smoker and never believed any of this evidence from observational studies about cigarette smoking and lung cancer. So again, the question for us as epidemiologists is, how much evidence do we need? How strong does that evidence need to be for us to overturn our prior ideas about a cause and effect question? Other criticisms might be made of the results of a study in which patients were interviewed after they had the disease, especially, did they remember it differently or did they give truthful answers? And today, when you think that most of your patients have been counseled by their healthcare providers, have been talked to by their relatives and friends about the adverse health effects of smoking, people might be motivated to try to conceal something. But in 1950, it wasn't really a prominent idea. But there still might be other issues of the information provided by someone with lung cancer and the information provided by someone who doesn't have it. So that's another possible criticism of this study.